The participants should be able to discuss the pathophysiology, incidence, prevalence, and mortality, morbidity associated with the disease, disorder, condition, syndrome being reviewed, along with the race, sex, and age range of persons typically affected. One objective. There's 9 more, including avoid medico-legal pitfalls. So I don't even know what that means, right? So you have 10 learning objectives. None of them mention hepatitis B, right? It says disease, disorder, condition, syndrome being reviewed, which led me to look at all of the other education that this particular provider did, and they use the same 10 learning objectives. So there's a platform that's accessible, that's free, that's available, that's 24 hours a day, that's just in time, but the content may not be good, or they're not embracing the power of the platform. So we have to think about it. And the other thing that comes to mind is when we have so much accessibility to this online content, what's going to happen to live conferences? Do you think live education is going to go away? No. I will tell you what we are seeing in medical schools. There are several medical schools in the United States that are digitally capturing all of their lectures. Attendance at these lectures is going down. Sort of looks like C-SPAN when you watch Congress. There's some congressman up there talking to nobody, right? But he has to get on the record. So he's like, I feel very strongly about this. And there's nobody in the room, right? So you see, but it offers people with different learning styles. Those who want to hear it live, hear it live. Those who only want to hear it digitally captured can hear it digitally captured. Those who want both can do both. So you are seeing drops in attendance in some of the med school courses, not in the CME courses, right? What about technology, where it fits in? See, I know where my bread is buttered. I said, okay, take a look at this. This came out just a couple weeks ago. Stanford School of Medicine equipping students with Apple's iPad. You think this is a good idea? Why? Absolutely, tools of the trade. And it also replaces some of the more antiquated things so that they have access to lots and lots of resources at their fingertips. Remember slide boxes, right? Remember bone boxes? They're all virtual. It's fantastic. I don't know if that's the case at Stanford, but it's certainly the case in a lot of other places. And we do see the digital platforms evolving. So we're seeing virtual 3D clinical environments. That happens to be on Medscape. We see everybody familiar with Epocrates. Epocrates was just a drug information tool, but they realized that they had hundreds of thousands of learners, so it became a great platform for the delivery of CME. Virtual tumor boards. So things that live in the real world are now existing virtually, and lots of other apps. Or we can simulate the clinical environment of a patient. So how about a patient that has to go to a primary care physician, get referred to a cardiologist, and then back to a primary care physician? Or the chest pain patient that presents to the emergency room, goes to the cath lab, and then is seen by a cardiologist afterwards. You can simulate the patient care continuum online, looking at virtual visits with short, little CME activities, micro CME, mini CME. You learn in the way you're accustomed to learn, and you go on. This is what's happening. There's lots of formats. So you can get CME on satellite radio. You can get CME on the doctor's channel. They're the ones who are here videotaping some of the content from this session and putting it up online. And what about social media? Is there a role for social media in CME? Yes. You sort of look at it with a little...
No, I put the face because of the Facebook thing in the case I was in Rhode Island, not because of the social media.
Right. So if you ask questions, so this happens to be a question that I posted in the National Kidney Foundation fan page, a question about a certain problem. And I asked physicians, caregivers, and patients. I got the answers. It was part of assessing the needs of the audience, so I developed the right educational content. Twitter, same thing. You can ask questions on Twitter and get the answers back. If you do so in a HIPAA-compliant fashion, you're not violating patient confidentiality, but it's opportunities to be interactive. The specialty societies are doing it. In fact, at the last ASCO meeting, they sponsored their own tweet up and sent 2 of their board members to interact with all the people that were live tweeting from the meeting. Sermo was here yesterday. Sermo is a fantastic platform for assessing the needs and delivering education to those physicians within the network. Now, certainly there are physicians outside the network, but you need to educate people where they are. So it's all a game, right? So we have, look, these are all real pictures. So here's someone who's just gotten a cast on his arm, and this physician is taking his phone out of his pocket and talking to his patient. Here's someone who's going over a radiograph, or someone who's sitting outside the OR at the point of care. Somebody said that before. This was in the Journal of Surgical Radiology in the current issue. It's happening just in time. That's where we win. We win the game if we're giving the education with the content that they need at the point of care and meeting the needs that they have. I'm going to close with my 10 predictions that you asked for, Daniel. I'm not going to expand on them because I have 37 seconds left according to the clock. We're going to see 1.0 move to 2.0. There's going to be interactivity, and we're going to see electronic medical records and CPOE and other data sources serving as a data set to see where we need education. We can look at HIPAA-compliant searches of EMRs to see where guidelines are being followed, where patients are being managed correctly. We can do education and then look at the data afterwards. What better data set than the most empiric set of data there, patient-level data? We're going to see far more education at the point of care. As the AMA has created AMA Point of Care CME, physicians can get credit. Get this. They identify a clinical problem, they look up a resource, and they say it helped or it didn't. They can get half a credit for that. You can get up to 20 credits a year for doing what you do anyway. Technology will fit both of the continuums that I talked about, the patient care continuum and the educational continuum. We're going to see a lot of this. And you want to read this one with me? Come on, say this one with me. Make me happy. Multi-inter-transdisciplinary education will be on the rise. What the hell does that mean? It means patients are treated by teams, not individuals. So why would we educate the teams separately? Let's teach them together, whether it's primary care and specialty, multiple specialists, physicians, nurses, pharmacists. If you manage a patient together, you should be taught together. My favorite thing, measure to treasure. You need to assess before, during, and after. See what the needs were before and see if you met those needs afterwards. Because if you didn't do that, the education can't be deemed successful. Just satisfaction with saying that was a good speaker and the chicken was good isn't enough to know that your education was good. You look at the forms, the evaluation forms at the end of an educational activity, that's what you see in the open column. Room was too cold, chicken was chewy, not enough muffins. I don't give a shit, right? I want to know if the education made a difference. The power of the platforms, thank you. Can you turn that around to everybody else? The power of the platforms will be harnessed. We will use the platforms not like the bad example, but like the good example. We're going to turn medical education upside down and inside out. We're going to involve the patient from the beginning, and we're going to bring everybody along the continuum appropriately. We're going to get personal. We're going to use personalized medicine. We're going to understand how we teach personalized physicians, about personalized patients, about that information. We're going to have to get the practicing physicians who aren't in this room to understand the information that's being discussed in this room. Social media will continue to be, or continue to rise in use in CME because we have to engage. We have to go to where the physicians are. We have to get that information. We're going to have to simulate and stimulate. Education has to simulate the clinical environment, and it has to engage you. If it doesn't engage you, you're not going to learn. Right? And I threw in a bonus one. We're going to see borders disappear, but not all live meetings are physicians. You may see primary care physicians disappear, but not for robots. For extenders and mid-level providers, and you'll see physicians in specialty care. But live meetings won't disappear, because otherwise you wind up with avatars of Peter and Daniel instead of being in this room. But there's not going to be an E-Singularity U. There's not going to be an E-Future Med. There has to be a live meeting, and that's going to happen. You tell me, how's medicine like stand-up comedy?
It's better live.
It's better live. Okay.
However good you think you are, the audience will always be tougher.
No matter how good you are, the audience will always be tougher, said the man hiding behind 3 screens.
And you got to keep practicing.
And you've got to keep practicing.
Killing the audience has a different...
Engaging. Yeah. The remnant of the prostate in women is the G-spot.
You all
There
learned
is
something
also-
this week. Okay.
There's also a simulation lab for that. That's an unconference. The answer is yeah. You have to know your audience, right? Pay attention here because this is going to be a history lesson. This is what TV doctors looked like in the 1950s. This is what they looked like in the 1970s. This is what they looked like in the 1980s. That was my favorite medical show ever. What show was that? St. Elsewhere. Love that show. ER and Grey's Anatomy. What we notice is we went from one physician teaching a very good-looking younger physician to casts of all good-looking physicians, which we know is absolutely the case, right? But we learned that it's a bigger and about a team. That's my talk. If you have any questions, comments, criticisms, concerns, kudos, or queries, you're out of luck because I used all my question time. Thank you for your attention. Enjoy the unconference and the rest of this meeting. Somebody